Hey there, everybody. All right, let's go ahead and get started with this Pharm review. Went ahead and started up my own Kahoot here, and we'll just kind of go through the questions, talk about them, and then if you have any follow-up questions, we can go over it and maybe email or in person. So here we go. We are ready, I believe. All right, so first off, which medication would cause iris discoloration? So let's look in here. We have pilocarpine, we have levobunolol, we have dorzolamide, and tafloprost. All right, so thinking about that one, I'm thinking, things that would cause iris discoloration. I would be thinking, glaucoma meds. I'm thinking prostaglandin, sort of analog. I think I'm going to go with tafloprost, right? It sounds like bimatoprost, latanoprost, kind of keeping that similar naming convention there. So let's go ahead and click that and see. All right, we got it correct. Wow, it was very unexpected. All right, let's go ahead and move on. Obviously, looking at things like levobunolol, that would be a beta blocker, would not be expected to cause iris discoloration. Pilocarpine we saw was used more as a meiotic agent. It would help with causing meiosis, and then dorzolamide, one of those carbonic anhydrase inhibitors we talked about. So again, iris discoloration, kind of that hallmark side effect you would see with the prostaglandins. And surprisingly, I'm in the lead. All right, up next, which of the following meds would most likely cause acute kidney insufficiency when initiated? We have drugs like hydralazine, we have prazosin, we have clonidine, which I believe I spelled wrong, and then we have lisinopril. So thinking about what could affect the kidney blood flow most significantly, we remember that by changing the vasoconstriction or dilation on the afferent and efferent arterioles, we can have pretty significant effects on actual kidney function, right? So we can cause an acute kidney insufficiency. This is more predominantly in patients who have kind of long-standing kidney issues. And so we know the Ang2 is going to be really important for causing vasoconstriction of that efferent arterioles. I think it's going to be lisinopril. Let's go ahead and go with that one and see if that's correct. And again, that is the correct answer here. Now, looking at hydralazine, we see that this is a direct vasodilator. Now, certainly, if you had very profound hypotension, this could lead to decreased kidney flow, but clinically, you don't really see that. You usually use this for patients with pretty high blood pressure to begin with, and so you could lower the blood pressure, but usually not to a point where they're going to cause kidney insufficiency. So that would not be correct. Prazosin being an alpha-1 blocker, again, very similar in action to hydralazine. So again, wouldn't really see that. And then clonidine would be more acting as a sympatholytic, kind of from the CNS down, causing decreased norepinephrine release, causing decrease in heart rate and blood pressure. Generally not going to have a direct effect on kidney function like something like lisinopril would have by affecting angiotensin II. Okay, just checking to make sure I was still recording. All right, moving on. Up next, which of the following would provide coverage against Legionella species? All right, so we're thinking Legionella. We're thinking about drugs that can affect atypical species. Typically, you kind of think of Legionella as an atypical bug. Same kind of categories like mycoplasma or say chlamydia. So two big things I'm noticing here. So Clinda, mainly going to be a gram-positive killer. I know that's not going to be very good for getting those atypical bugs. I know cefazolin or Ancef, again, probably not going to be very good here as far as getting those kind of that spectrum of bacteria. And now certainly they could get strep pneumo, right, if I was worried about that for say like a pneumonia. But if I'm more worried about the atypical coverage, I'm thinking about things like macrolides, or I'm thinking about things like fluoroquinolones. And so in which case I'd probably end up going with the macrolide first, as this is a more narrow gun as compared to a fluoroquinolone. So let's go ahead and go with that one. And again, I'm not making all of these the green button here just happens to randomize to that. But anyway, so you see there's two correct answers here. So again, the fluoroquinolone could have been a decent option. Say someone had an allergy where they could not receive azithromycin, or maybe there's a significant drug interaction. We know macrolides inhibit CYP3A4, so we may not want to have that kind of interaction to deal with. So certainly fluoroquinolone could be a decent backup here. All right, moving on. Next up, a patient with chronic constipation should avoid which medication? All right, we have diltiazem, we have minoxidil, we have bumetanide, and then prazosin. So thinking back to things that can affect the GI tract to slow things down, to maybe inhibit that smooth muscle contraction. I remember that calcium is very important for smooth muscle contraction, and so maybe something that prevents calcium influx could affect this. So I'm going to look for a calcium channel blocker. Prazosin would not be that. It's an alpha blocker. Bumetanide being a loop diuretic. Minoxidil being a direct arterial dilator. So that would leave us with diltiazem, which would be a non-dihydropyridine calcium channel blocker. Right. So again, knowing the mechanism helps us to understand why some of the adverse effects occur as they do. Right. So which medication can mitigate the unique side effect of immediate release niacin? Okay, so what is that immediate release niacin kind of unique side effect? Well, I remember it has a lot to do with my friends who did that niacin challenge. I remember my friend came to the car when I was picking her up, and she was very flushed from head to toe. She was very red, had vomited, was sweating. A lot of that has to do with prostaglandin synthesis. So I'm going to look for something that can help me to block prostaglandin synthesis. So 2 drugs I can knock right off the bat, knock out of the running would be things like torsemide, which would be a loop diuretic, and hydralazine, as we've seen already, is a direct vasodilator. So those would not be the correct answer. Next, I have acetaminophen. Again, not a clear mechanism of action, but certainly will not affect things like prostaglandin synthesis. So that would leave us with aspirin, which you can kind of consider like a non-steroidal anti-inflammatory drug. Would have those effects on cyclooxygenase. So let's go with aspirin. And that's generally recommended. It's not, we don't have to recommend it all the time anymore due to a lot of extended release niacin products, but it's one of those kind of unique things that if you did have a particularly susceptible patient to the side effect, you could treat with aspirin beforehand, and that can help to mitigate that. Next up, mydriasis can be caused by which medication? All right, so we have fluorescein, we have trypan blue, we have carbachol, and we have cyclopentolate. So which one would cause mydriasis? So we know that we have a couple staining agents here. So we have things like fluorescein, which you guys did on your notes for ENT, you saw, or for opto, I guess. You can use that for staining to look for things like corneal abrasions. So that would certainly not be it. We have trypan blue, which is another dye that we can use for things like vitrectomies. So that'd be used more like kind of opto surgery. Carbachol was more of a cholinergic acting agent, so that would actually cause meiosis, if anything. So what we can use is a drug called cyclopentolate, which is a cyclopelagic agent, as we call them, and would actually cause mydriasis. So it can be very useful if you're trying to do some exams, fundoscopic exams, things like that. It can be very useful for helping kind of open up the eye and be able to get a better view. So used pretty frequently by our ophthalmologist who say present to the ER for some of the particular eye complaint. All right, which medication has the slowest onset of action for treatment of chronic treatment of asthma? So looking at this, looking at onset of action for management of chronic asthma is important to understand. Like when you're educating patients, is this one going to work fast? How long is it going to take to really kick in before you start to see benefit? So looking at these, we obviously know albuterol would not be a correct answer because that's going to be for acute management of asthma, and that would actually be the fastest acting. On the other hand, we can know that things that will affect production of inflammatory cytokines from the kind of the nucleus up, from the protein transcription, that a steroid would be able to have the slowest onset of action, but generally has one of the most powerful kind of effects on this chronic treatment. So I'm going to go with the corticosteroid, which is going to be mometasone here, or Asmanex. So why are the other ones not going to be effective, or would not be considered the slowest acting? If you look at something like omalizumab or Xolair, this is actually directed directly against IgE. So if IgE is what's causing the asthma exacerbations, by binding all that up, and again, this is an immediate sort of effect, you could end up seeing much more quick actions than you would see with something like a corticosteroid, which can take up to a few weeks before it really gets kind of fully efficacious. Similarly, with theophylline, it will have its effect more immediately. And in fact, we can actually use this for very severe acute asthma exacerbations like status asthmaticus, because it's doing things like inhibiting phosphodiesterase to cause bronchial smooth muscle relaxation. It's inhibiting adenosine. It's doing all these different things that will have a much more immediate effect than mometasone would itself. Okay. So a patient with uncomplicated bacterial conjunctivitis should be treated with which medication? So we have ganciclovir, we have natamycin, we have erythromycin, and moxifloxacin. All right, so we're looking for specifically a bacterial conjunctivitis, something that can treat that. So I want to make sure I get rid of things that are not going to treat bacterial infection. So ganciclovir, vir is right on the end of the name there, so we know that that would be incorrect. Natamycin, we know that this is actually an antifungal agent, so that would also not be good for treating a bacterial infection. So now we get narrowed down to between erythromycin, we have moxifloxacin. So, the question is, when is it appropriate to utilize a fluoroquinolone? Generally, if you're shooting for treatment of something like Pseudomonas, that's where you're going to get much more kind of utility out of using that. We don't need to go with such a broad spectrum kind of big gun, such as a fluoroquinolone. We can use something very basic, very kind of trusty standard. So we're going to go with erythromycin here. And that would be the correct answer. Now, could you have treated this bacterial infection or bacterial conjunctivitis with moxie? Chances are, yeah, it would also probably have worked. But again, in this case, we're kind of looking for like the best answer. So if we're not shooting for Pseudomonas, generally kind of avoid your fluoroquinolones unless you have some other kind of compelling indication. All right. Which of the following medications is safe to smoke with? And by this, I mean smoking tobacco. So here's some drugs we can use to help us to kick the smoking habit. We have varenicline or Chantix. We have nicotine gum, albuterol, or bupropion. So which one of these would be safe to smoke with? And I probably should have specified, because I don't think I thought this one all the way through, that medications to actually help treat nicotine addiction. So looking at this, we could see that nicotine gum would be out, right? We wouldn't want to use this because mainly you get too much of the nicotine effect. So if I was chewing the gum, I was smoking a cigarette, it's a lot more nicotine than I kind of bargained for, and you can see some toxicity from that. So that would be incorrect. But looking at some of the other ones, bupropion, that has no really direct nicotinic action, and the varenicline only has a partial nicotinic action, so it actually prevents other nicotine, say from smoking, coming in and affecting this. So it's kind of dealer's choice here, so I'm going to go ahead and go with Chantix. So I did think this one all the way through, even though albuterol would be something that would maybe treating a complication of cigarette smoking, like asthma exacerbation or possibly like COPD. This one would also be safe to use along with that. So several right answers. Again, on the test, I will only give you one right answer. All right. Which medication would be recommended in a patient with an isolated hypertriglyceridemia? Okay, so we're looking for things that can directly affect hypertriglyceridemia. Things will be indicated specifically for that indication when maybe the rest of the cholesterol panel looks pretty good for the most part. So the question is, what of these classes of drugs can really affect this? And so going back, the mechanism of action doesn't directly kind of inform this. You kind of have to know just the characteristics of the different classes of drugs here. So we know atorvastatin will have very good effects of dropping LDL. Will also affect triglycerides, but not nearly to the same effect as one of these other classes will. We also have a bile acid sequestrant. We also have a ezetimibe, which is a cholesterol absorption blocker. And then we have a fibrate here. Fibrates tend to have pretty good effects on HDL, and then more primarily, in this case, we're looking for the triglyceride effect. So again, fibrates would actually be the correct answer in this case. Similarly, niacin has pretty good effects on triglycerides as well, in addition to heading up HDL or increasing that. But here in this case, the fibrate would be the correct answer, or the best answer, I should say. Certainly, if it was kind of a mixed picture, if there was, say, increased LDL in addition to high triglycerides, maybe a statin would be a better option. But in this case, fibrates work. All right. Which controller medication is used in COPD but not asthma? All right. So we have beclomethasone, which we would know to be a corticosteroid. Hey, sorry guys, I had to take a quick break in there so that I could answer a few of your classmates' questions. But anyway, so going back to this question of COPD and what med you would use for treatment of that for controller kind of chronic maintenance versus something we might use for asthma. The big thing you'll see is that we still use drugs like beclomethasone, which falls into the corticosteroid category. We still use drugs like albuterol for some of those acute exacerbations, and ipratropium can be used occasionally, again, kind of a short-acting med in conjunction with like something like albuterol. The big one here is to note is that tiotropium or Spiriva. This is a long-acting anticholinergic, which is kind of in the same, kind of a cousin to ipratropium, kind of the short-acting version of that. Tiotropium being long-acting, you get kind of better controller type of effects out of that drug. And so, yeah, so we do that for COPD. We not clinically indicated for asthma for whatever reason, whether the studies just haven't been done or they found it ineffective previously. This is just not one we use for those patients. All right. Sudden withdrawal of which medication could lead to severe rebound hypertension? This is a question kind of regarding, what drugs will cause, kind of upregulation of a lot of these adrenergic receptors. What's going to increase our beta receptors and alpha receptors by, chronically being blocked potentially. So several things here. So looking at drugs like irbesartan, that is going to fall into that category of an angiotensin receptor blocker because it's an sartan. Amlodipine would be a dihydropyridine calcium channel blocker. And then chlorothiazide, it would be a thiazide diuretic by the name. So really, the other last one we have here is nadolol or beta blocker. So again, that rebound hypertension is mediated through kind of an exaggerated sympathetic nervous system effect. So let's look at the thing that's going to be affecting the nervous system, sympathetic nervous system directly, and that's going to be the nadolol, the beta blocker here. So again, you don't really see that same kind of upregulation of beta or alpha receptors when you're kind of monkeying around with things like irbesartan, amlodipine, chlorothiazide. Other correct answers that I could have put here would include things like alpha blockers. If you had an alpha blocker like prazosin on board for a long period of time, you could have upregulation of those receptors, and if you remove that, it can have severe rebound hypertension. Similarly, clonidine, guanfacine, any of those centrally acting alpha-2 agonists could do a very similar effect as well. So again, think about how they're affecting their direct kind of cellular targets, and think about what those rebound effects could be potentially. You really don't see these kind of withdrawal effects with diuretics. You don't see that with the angiotensin receptor blockers or any kind of the renin-angiotensin system inhibitors or calcium channel blockers, fortunately. All right. Which of the following can cause bradycardia in patients with significant nasolacrimal drainage? All right, so we're thinking, what are things that can cause bradycardia? We're looking at things like brimonidine. Potentially that could cause some effects, if it were to get more centrally located, because again, it's another one of those alpha-2 agonists. Fortunately, though, you find that due to their kind of physiochemical charge they have on them, it makes it difficult for it to cross the blood-brain barrier. So you don't see a ton of those effects here with things like brimonidine. Obviously, latanoprost or prostaglandin would not do this necessarily. Tetracaine is an anesthetic, would not necessarily cause bradycardia, but we do have cardiolol here, which again would be a beta blocker. And this is a clinically significant concern. If you had a lot of drainage happening here, you could have a lot of mucosal absorption, and then you can definitely see bradycardia as a possible side effect. So cardiolol would be the correct answer here. All right, moving on. Next, what is the name of this Nintendo character? I think this is going to be a continuing trend for me here to include some of these video game knowledge questions. So we have Pit, we have Link, we have Wario, and we have Icarus. Which one could it be? I'm going to go with Pit here. Right, so those of you who are astute Nintendo kids growing up, that actually came from Kid Icarus, but his name is not Icarus. His name is actually Pit. And again, if you were a Sega kid instead, I pity you, but that's okay. I won't hold it against you. Anyway, moving on. Which anti-lipemic would be best for a pregnant patient? So we have drugs like ezetimibe, we have gemfibrozil being a fibrate, we have cholestyramine, which would be a resin, we have rosuvastatin. Remember, the thing we said with our anti-hyperlipidemia meds is that you don't want to mess with things like hormone synthesis. You don't want to affect with cell wall synthesis or cell membrane synthesis with pregnant patients, trying to develop this fetus. So most of these are going to be not recommended for pregnancy. Fibrates, statins, ezetimibe, not going to be really recommended. Really, the only thing we can do are give drugs that don't get absorbed systemically, and they're going to be affecting that bile acid that you're sending out from the biliary tract. So again, in this case, it would end up being the resin. So cholestyramine would be the correct answer here. Next, which beta blocker would be best for a patient with poorly controlled asthma? All right, so patient with asthma, we know we don't want to be affecting our beta 2 receptors. So which of these drugs could be, beta 1 selective, would help to kind of spare those beta 2 receptors so that things like albuterol can still affect it. So if we remember our kind of naming convention, remember that for the most part, A through M, or Apple through Mary, those tend to be beta 1 selective beta blockers. N is in Nancy through Z tend to be non-selective beta blockers. Remember, there's that third generation that kind of bucks the trend, so to speak, but in this case, this will hold true. So pentalol would not be it. Propranolol definitely we know is non-selective. Sotalol, which I believe I spelled incorrectly. It's tough when Chrome does not catch your spelling errors, but regardless, we have metoprolol, and this absolutely is a beta 1 selective beta blocker, so this is going to be our correct answer. All right, next up, which of the following is able to affect blood pressure and heart rate from the level of the CNS? So we're looking at something that's not going to be directing the vasculature directly. We're not looking for something that affects the myocardium directly. We're looking for something that's going to be working kind of more centrally acting. So we have things like verapamil, which is a non-dihydropyridine. This is going to have balanced effects between the vasculature and the myocardium. Things like felodipine would actually be a dihydropyridine, which again would have relatively little to no direct cardiac effects, but would certainly be affecting the vasculature. We have minoxidil, which we know is a direct arterial vasodilator, and then we have clonidine. Clonidine is a alpha-2 agonist, and we know that by affecting alpha-2 receptors and from the CNS down, this is going to help to drop our blood pressure and heart rate by being a sympatholytic. So clonidine would be the correct answer here. Guanfacine would have been another correct answer, 10x or intuitive. And again, you're going to see clonidine used for a lot of other indications. So for instance, for my purposes in pediatrics, we don't see clonidine being used very often for blood pressure control. We oftentimes see it used more for as an adjunct to ADHD. Sometimes we'll actually see this being used intrathecally to help. We give it in conjunction with things like anesthetics like ropivacaine. We use that for chronic pain control. So lots of uses for clonidine. Besides just blood pressure. So if you see it, not necessarily being used as an antihypertensive. Which of the following drugs can cause CYP3A4 induction? So we're going to be inducing CYP3A4. It's going to help to drive levels of other drugs that are substrates of 3A4 down. So we have a couple of our TB drugs. We have things like pyrazinamide. We have rifampin, isoniazid, ethambutol. Kind of one of the classic CYP3A4 inducers you always kind of jump to is going to be rifampin. Yeah, so that's the primary one that really induces 3A4. It can drive levels of other drugs down due to more enzymes being more plentiful, able to metabolize those drugs. All right, which of the following medications would worsen left ventricular function in a patient with CHF? All right, so again, we kind of talked about this previously, but we're looking for something that can directly depress left ventricular function that could potentially worsen their CHF, right? So we're looking for things that are directly affecting the myocardium. This can include things like beta blockers affecting the beta 1 receptors. This can include our non-dihydropyridine calcium channel blockers. This would not include things like dihydropyridines because we know they mainly are going to affect afterload by affecting that total peripheral resistance. Ramipril, or which would be an ACE inhibitor, this would not be affecting direct cardiac effects. Certainly can help with left ventricular remodeling over the long term, but it doesn't cause direct depression of that. So in this case, I'll probably either go with verapamil or propranolol, and I'm hoping I selected both of these as correct, but I'm going to go with verapamil. And I did. I selected both of these as being correct. So you have to be really careful with utilizing these kind of direct cardiodepressants for patients with CHF. Poor ejection fractions or poor left ventricular function, because you can throw them into a CHF exacerbation. They can land them in the hospital very, very easily, depending on how kind of progressive their disease is. So again, think about the mechanism, think about where it's working specifically, and what kind of effects you can see here. Verapamil is relatively contraindicated for a lot of CHF patients, but occasionally you will see patients being put on beta blockers. And we mentioned there's 3 of them that we can use for CHF specifically. We'll talk much more about that in the next section of the class. So again, I will leave you on the edge of your seat waiting for that answer. All right, which of the following would be most likely to cause bradycardia? All right, so we're looking here. We see which of these drugs can cause bradycardia. So we have things like guanfacine, we've talked about as being kind of a central sympatholytic. We have dotaizin, which is a non-dihydropyridine calcium blocker. We have terazosin, or terazosin, which is a alpha blocker, and we have a dihydropyridine here, nifedipine. So based on what we've already talked about, it should be pretty clear cut as to what could cause bradycardia. We know that things that are acting as a sympatholytic from the CNS can certainly do this, and we know that direct cardiodepressants like either beta blockers or something like a non-dihydropyridine calcium channel blocker, verapamil and dotaizin, would do that. So again, we have 2 correct answers here. Again, if I put a beta blocker, that would also have been a possible correct answer. So I'm going to go with dotaizin. Now, unfortunately, I was not smart enough to actually key the guanfacine as a correct answer. In terms of likelihood, you're probably more likely to see diltiazem actually cause direct bradycardia just due to how directly it's affecting the myocardium. Guanfacine, again, I would consider to be a correct answer, but again, I was just goofy and did not key that as a correct answer. But it could also cause bradycardia. Probably not quite as likely as diltiazem, but I certainly would have accepted it as the right answer if you had challenged me on this on a test. Hopefully that will not come back to bite me in the butt. All right, which medication would be appropriate for coverage against Pseudomonas and ventilator-associated pneumonias? All right, so we're looking here, see what could cover Pseudomonas for ventilator-associated pneumonia. We have vancomycin, we have ceftriaxone, we have piperacillin, tazobactam, and levofloxacin. Remember, this is one of the situations where oftentimes you're double covering for Pseudomonas, so you may use something like a cell wall inhibitor plus, like, say, a topoisomerase inhibitor or a protein synthesis inhibitor. You know, you're using two drugs, different mechanisms to try to get some synergy to make sure you overcome that resistance for Pseudomonas. So looking at this, we know vancomycin would be thrown out. This is a gram-positive killer only. Ceftriaxone, while it is good broad coverage for many gram-positives and many gram-negatives, more importantly, does not cover Pseudomonas. Cefepime would have been a correct answer here. Instead, we have levofloxacin, which would be a fluoroquinolone. Certainly does have coverage in a lot of cases. You may see some increased resistance as time goes on. And then piperacillin tazobactam is an anti-pseudomonal penicillin. So let's go ahead and go with piperacillin tazobactam. And we see that both of these are correct answers. So either Levaquin or Zosyn would have been a correct answer here. Right, a patient develops rhabdomyolysis after taking simvastatin and what other medication? So we have alirocumab, we have lisinopril, we have verapamil, and ezetimibe. All right, so which one of these could cause this interaction here? Now, if you remember simvastatin being one of those statins that gets metabolized by CYP3A4, so we know this is a most likely reason to have levels increase and see hepatotoxicity, see potentially rhabdomyolysis occur here. So we're looking for something that inhibits 3A4. Alirocumab is a very specific, very targeted sort of molecule that's affecting that PCSK9 receptor or enzyme. We have lisinopril, which we know does not have any significant interactions from a CYP inhibition activity. Ezetimibe similarly would not have any interactions here, but certainly verapamil. This is a big one to think about. It's having the ability to inhibit CYP3A4. So I would go with verapamil here, and that would be the correct answer. A patient complaining of seasonal conjunctivitis would most benefit from which medication? All right, so we have, again, this is more of an allergen-induced sort of conjunctivitis. So we have bacitracin, tetrahydrozoline, brinzolamide, or cyclosporin. All right, so we're thinking, what kind of drugs can we use here? They're hyperemic, they're having increased tearing. I want to use something that can work as kind of a vasoconstrictor. That could be one of the things we can use to help kind of treat those symptoms. Bacitracin would not be correct because that would be a drug used to treat bacterial infections. Cyclosporin is actually a drug we will use as an immunomodulator to actually help increase tear production for people who have, like, say, autoimmune conditions where they have really bad dry eye. And then brinzolamide we know would not also be correct. This is a carbonic anhydrase inhibitor used for glaucoma. So that would leave us with tetrahydrozoline. It's one of these imidazoline derivatives that, again, is affecting those alpha receptors in the eye and the conjunctiva to try to cause vasoconstriction. That would be the correct answer. All right, which of the following diuretics would exacerbate hyperkalemia? We know a lot of diuretics end up causing increased excretion of potassium, but which one of these here would actually cause increased retention? We have things like acetazolamide, a carbonic anhydrase inhibitor. We have furosemide, a loop diuretic. We have metolazone, which would be a thiazide diuretic, and we have spironolactone, a aldosterone antagonist. So again, thinking about this, most of these are going to cause potassium excretion, but we know that by affecting aldosterone within the collecting duct, this is going to cause us to leave more sodium out in the renal tubule, but we're going to hold on to more potassium. This would be considered sort of a potassium-sparing diuretic, so we're going to go with spironolactone. And this is why you might see something like Lasix, furosemide added to spironolactone, or vice versa, because that way they can kind of offset the potassium wasting sort of effects here, right? So again, potassium levels are very important to monitor for when you have any of these patients on diuretics. Which medication is appropriate for an acute asthma exacerbation? All right, so we have montelukast, we have ipratropium, salmeterol, and we have fluticasone. Which of these would be good for an acute asthma exacerbation? Now, most of these are controller medications. We know salmeterol, being a long-acting beta agonist, is not going to be effective for acute treatment. Again, you don't want to give long-acting beta agonist to asthmatic patients by themselves anyway. You need to give this in combination with the corticosteroid. Again, not super fast-acting. Similarly, fluticasone had the slowest onset of action here, as we discussed previously. And the montelukast being a leukotriene receptor antagonist, again, similarly ineffective for acute treatment, better for as a controller medication. Ipratropium, though, certainly can be given in conjunction with albuterol. That's where we get those duo nebs that we give to treat acute asthma exacerbation. So this would be the correct answer. Because again, this is a short-acting anticholinergic. That's going to be your best bet. Okay, so you're concerned, concern for MRSA pneumonia in a patient. Which antibiotic would cover this? We have linezolid, we have dicloxacillin, which again I spelled that incorrectly. We have daptomycin and azithromycin. So the question is, which of these are going to be gram-positive killers that include MRSA coverage? We know azithromycin is not going to be good for that. It has some gram-positive coverage, but certainly not MRSA. Dicloxacillin being a anti-staphylococcal penicillin, but only good for MSSA. And so we're left with linezolid, which we know is a great gram-positive killer. We have daptomycin, another great gram-positive killer. Question is, treating pneumonia, which of these can you not use in pneumonia due to the surfactant in the lung actually disrupting it and making it ineffective? That would be daptomycin. So really your only option for MRSA coverage tends to be things like linezolid, vancomycin when you're talking about pneumonia coverage. So we're going to go with linezolid here. And that would be our correct answer. Now, if you're doing like a skin soft tissue infection, Dapto would be a great drug to use in that case. But in this one, we're going to stick with linezolid because it retains efficacy for pneumonia. Next, which med would have the fastest onset of action for treating all symptoms of anaphylaxis? We have epinephrine, we have sodium chloride, we have diphenhydramine, and methylprednisolone. So looking at this to see which have the fastest onset of action for treating all of these symptoms. And some of you have probably already correctly guessed epinephrine. You can talk through that. Certainly epinephrine would be the correct answer. This is the fastest onset of action. It treats all these effects of anaphylaxis, helps with the bronchoconstriction, it helps with the hypotension, can help to mitigate a lot of the vasodilation that's occurring here. And so it works very, very quickly. And that's oftentimes when you have a patient with anaphylactic reactions will be the first drug we give. Diphenhydramine is going to be good, but it's not going to affect a lot of those other really life-threatening sort of symptoms. But it's good for like the urticaria, good for the itching and whatnot. And this is probably kind of a badly worded question to treat all symptoms. Probably should have said, treating life-threatening symptoms, I should say. No one's going to itch themselves to death, certainly. But certainly someone can have airway compromise that would lead to respiratory failure. So that's why you can put epinephrine. That's kind of what I was kind of focusing on. Certainly you give these two in conjunction pretty close together. Methylprednisolone is going to be very effective for treating especially those late phases of inflammation. However, it does not work super quick. It's going to take a few hours, especially if you give an IV. It's the fastest way you can get it to work. Still takes some time, so it's not going to be super effective for those acute symptoms. And then sodium chloride, while good on good for helping with the hypotension, it does not treat really any of those other symptoms. So it's not going to help you to prevent airway obstruction. It's not going to help with any of that stuff, but it does help to get the intravascular volume filled up, so where it can help to maintain their blood pressure. Which of the following medications can help preserve renal function in diabetics? So looking for things that are going to be nephroprotective. Things like furosemide, atenolol, quinapril, and then candesartan. So remember that a lot of the kidney remodeling effects that occur after chronic hypertension, chronic hyperglycemia, tend to be mediated through that renin-angiotensin system. So we're going to be looking for things that help block the effects of angiotensin 2, so that kind of limits our, kind of throws out things like furosemide or Lasix, which is a loop diuretic. It throws out things like atenolol, which would be a beta blocker. This would actually be a cardioselective beta blocker because it starts with A here. So that leaves us with candesartan and quinapril. Therapeutically, either of these are going to be effective as a nephroprotective drug. So you can go with either candesartan or quinapril. Both of these would be therapeutically correct. Now remember, ACE inhibitors can cause an acute decrease in kidney function, especially for patients who are really dependent on the Ang2 effect on the efferent arteriole. This is why you start low, you titrate up gently to see how they tolerate it. You're monitoring renal function. You're looking at their potassium levels because we remember that renin-angiotensin system inhibitors can increase potassium. You're monitoring all of that stuff as you're, again, working on their blood pressure, getting that down, monitoring their renal function to look for progression of disease. Again, you can't fix their kidneys with the ACE inhibitor, but you can hopefully slow down the progression of kind of further destruction. All right, a potential side effect from use of evolocumab or Repatha is undetectable LDL, anaphylaxis, rhabdomyolysis, or infection. So again, we're looking at evolocumab. It's a monoclonal antibody against that PCSK9 enzyme that helps to prevent recycling of LDL receptors. You have more LDL receptors on the hepatocyte surface. You're going to be able to get rid of more LDL particles from the blood. So what could this do for us? Rhabdomyolysis. Pretty unlikely. It doesn't really have any effects on muscle toxicity like a statin would do. It doesn't really have any CYP enzyme inhibition effects we're concerned about, because again, these monoclonal antibodies are laser focused against one specific target, very similar to how you have antibodies specific against things like measles or tetanus. So again, you would not see those effects here. Infection. While we do see that a lot of the monoclonal antibodies can cause immunosuppression, I'm just going to go ahead and click an answer here because I'm worried about running out of time. Anyway, while we are worried about infection for a lot of monoclonal antibodies for treatment of things like autoimmune conditions like Crohn's disease or rheumatoid arthritis, those tend to be immunosuppressive in a lot of cases because they're affecting things like interleukin, tumor necrosis factor. However, in this case, we're targeting a target that has nothing to do with the immune system. It has to do with recycling those LDL receptors. So anytime, though, you're giving a foreign protein, such as a monoclonal antibody, you do want to worry about anaphylaxis. You really have to monitor for this and make sure the patient's not going to have an allergic reaction. May not be the first dose, could be with the subsequent doses. Got to be careful with that. The other thing, I kind of just point this out here, is kind of a clinical sort of anomaly. Patients were actually found in some trials to have an undetectable LDL. Now, we don't know if this is actually dangerous or not, but it's something that is certainly reported in a lot of the literature for these drugs. So again, time will tell to see, is this something that's actually dangerous for patients? We just don't know, because this is the first drug we've ever had that's been able to get someone's LDL to undetectable levels, right? So statins are pretty good. They're not that good, though. And the last question, which of the following could cause cyanide toxicity in patients with liver dysfunction? All right, so we have things like nicardipine, we have phenoldipan, we have tamsulosin, and nitroprusside. So as you guys remember, nicardipine being a dihydropyridine calcium channel blocker, phenoldipan being that dopamine agonist that can kind of help with renal perfusion. We have tamsulosin being a very specific alpha-1 receptor antagonist. This is good for benign prostatic hyperplasia or BPH. But nitroprusside, that is a direct vasodilator. It's very good. We use it a lot in ICU settings to try to get patients' blood pressures down. This is the one that actually contains cyanide with it, and so that can actually cause toxicity if your liver is not up to the task of getting rid of that cyanide. And oftentimes we give that drug sodium thiosulfate. It's a sulfur donor that helps our liver to get rid of that cyanide a little bit more effectively. So nitroprusside would be the correct answer here. And again, it's kind of a unique kind of side effect due to the chemical composition of the drug. So anyway, turns out I did super well, except I couldn't even get 100 on my own test. But I'm going to blame that on you guys for coming in and asking me such great questions, and I'm glad I get to have these fun kind of interactions with you guys. So feel free. I'm sorry I can't do this in class due to a lack of time and a breadth of material. But if you have questions, please email me, stop by my office, whatever you need to do. I'm trying to get back to you as soon as I can. Thanks so much, and I will see you guys soon.